Hello, everyone. I'm Bill Zoghbi. I'm the chair of cardiology here, and it's a pleasure to welcome you to our multimodality imaging conference. And with me today is Dr. Chang, Associate Director of Cardiac CT, and Dr. Dipan Shah, Director of Cardiovascular Imaging here, as well as Cardiac MRI. And I think today we're going to have a great topic, bring all the expertise in imaging to evaluate a difficult disease, if you think, prosthetic valves and how to evaluate function and regurgitation. So it's a big topic, and we'll try to squeeze it within 1 hour timeline, and we welcome your questions. And if you want to send your questions, there are two ways to do it: by text. If you text the word DeBakey, DEBAKEY, to 37607, or if you can go online to Paul Ev, or Paul Everywhere, POLLEV.com/DeBakey, and send us your questions as we go along in the discussion and the presentation. So it's great to have that. And I will start with echo Doppler. I'll take the prerogative of the chair and spend a little more time than our friends in CT and MR. But truly, because echocardiography, I think, all other modalities would acknowledge that it is actually the first line of evaluation of patients after they undergo replacement or repair nowadays of a valve with a prosthesis or a catheter-based repair. So this picture is just to show you the dilemma at times we have, be it the clinicians or the imagers, as to what we are dealing with. Certainly it's not the native valve. There's so many different ways of replacing or repairing valves with either percutaneous or in patients with homografts, they don't have any prosthetic material, and the image actually at times may look almost identical to a native valve. And nowadays, I think the vast majority of these prostheses, the mechanical ones, are with bileaflet prosthesis, although we still see some remnants of the other different mechanical prostheses. So I'm going to go first through some of the basis of how do you evaluate function. So we're not looking at regurgitation, we're looking at function. If you want to be left with three important messages, is remember to identify valve size. Hopefully that will be in the record and should be in your reports so that it can be seen from one examination to another. Valve type, as well as the flow rate, which will determine the velocity or the gradient across these prostheses. And I think that's going to be very important. The other is probably one caveat regarding mechanical valves, particularly the bileaflet prosthesis. And if you see that here, there is a gradient, or there is an acceleration of velocity between the two leaflets. And what does this mean from a flow dynamics is that the velocity is higher there. And therefore, when we try to evaluate gradients in these prosthetic valves, you cannot differentiate the gradients that is smaller in the larger orifice versus the smaller orifice. So there is an overestimation by Doppler using the Bernoulli equation compared to catheter-based gradients of the 4V² formula, particularly that it is in the far field, so you cannot differentiate these two. The good thing is that all the normal values that you see reported in the guidelines are those incorporating this overestimation of gradients, and the effective orifice area therefore is actually smaller than actually normal, and that's also put in the reference values that you have. You don't see this phenomenon in bioprosthetic valves or in homografts. Now this is for your information, and I would refer you to these important guidelines. They have not been updated because there is really no urgency for the update. The only thing that we will talk about later is the new guideline regarding percutaneous valve procedures, particularly the repair procedures, TAVRs, and the alike. So this is for your reference. I think that's important for you to keep that in mind. Now, in general, when we see patients in our clinics and the imaging laboratories, clinical information is crucial to get: date, of valve replacement, type and size of the prosthesis, height and weight of the patient, and body surface area, because I think it's important in prosthesis patient mismatch, with a caveat there that in the obese patient, particularly BMI greater than 30, be careful of overestimating or over-evaluating prosthesis mismatch, because you're dividing by a larger number than should be really for normalizing for body habitus. Symptoms, blood pressure and heart rate are important. And let's take an example here. This is a prosthetic valve, mechanical in the aortic position. Velocity on the right is almost reaching 3, like 2.7, 2.8. Is this normal or abnormal? Actually, studies from our laboratory and others have evaluated this. So just take this example. This is a St. Jude medical valve by leaflet. We know the valve size on the x-axis, and watch what happened to mean gradient. There is so much variability in gradients alone, and that could be velocity, that could be maximal gradient. And you understand why some of that is, besides variability, is that the flow may be different in these patients. And that's why deriving an effective orifice area is one way to correct for that, using the same equation that you use for native aortic stenosis. And you could see that the spread is much less, going from a 19 size valve all the way to a 31 in the aortic position. Notice though that the normal valve areas, effective orifice areas for a 19 valve, average almost a 1 centimeter squared, and can be even as low as 0.75, which is a bit surprising, but yet at the same time, this is what normal is, because in the smaller valve, the overestimation of gradient is higher. Where you overestimate a lot is high flow situation, as well as small valves like a 19 valve or so. Now, one index that we proposed, and as well as others, and it is in the guideline, is the Doppler velocity index, which is simplistically is how much did this velocity increase from the LV outflow tract all the way to through the prosthesis. Now, ideally, if there's no valve at all, the ratio of velocity in the LVO to jet will be 1. You will never see that. And normality is this acceleration is less than 4 times what it is. And therefore, this velocity ratio should be greater than 0.25. Most of the time, you will see it somewhere in the 0.4 range or so for normality. And in TAVR, because the flow profile is so much better in these valves, is close to 1. Actually, the vast majority is above 0.5, even 0.75. This is for a St. Jude bileaflet prosthesis. And notice that the good thing about this Doppler velocity index is less dependent on valve size. Watch that throughout from a 19 all the way to 29 or 31, the Doppler velocity index is about 0.4 or so. And the reason for it is, since you're excluding the LVOT diameter because of the size of the prosthesis and because the surgeon will put in something commensurate with it, you simplify the continuity equation to exclude that. And I think it's great, because if you don't know what the size of the prosthesis is, this Doppler velocity index comes in really very handy regarding that. So let's take a look at an example here of a normal versus obstructed valve in the aortic position. Notice that in an obstructed valve, the ejection time is longer, peak velocity is higher, mean gradient obviously is higher, and also the acceleration time, which is an index from the onset of ejection to the maximal velocity, longer. Normally, this acceleration time should be less than 80 milliseconds. And if it is greater than 100, you start wondering. Certainly greater than 130 milliseconds, it's almost diagnostic of an obstruction. And in this patient had 180 milliseconds. And this is in the guideline that was suggests stenosis greater than 4 meters per second. A DVI less than 0.25, valve area less than 0.8. Rounded and symmetrical contour, although it is qualitative, is still very important, and an acceleration time that is large. Very important is that an individual should have a post-op study. A Doppler study is almost like the fingerprint of what that prosthesis velocity, normal gradients, and everything else, all these parameters are in a particular patient. And because there is variability among patients, and I think it's great for you to be able to see that. You could do that just before discharge. That's what most people do, although it may not be completely ideal, but you could do that about 2 to 3 months once the hemodynamics are back to normal. Let's switch to prosthetic mitral valve. And obviously, if you have a normal prosthesis, even the velocities of ENA and sinus rhythm will be higher than normal. But in an obstructed valve, gradients and velocities are higher, pressure half time is longer, and I think these are the things that we would look for. The Doppler parameters that we use are maximal velocity, mean gradient. However, please, if you are the reporting physician, report a heart rate always with it, because it is very heart rate dependent as opposed to, let's say, an aortic prosthesis. Pressure half time is an index. Don't use it to derive a valve area, because at times you may come up with some numbers that don't make any clinical sense. If you want to use an effective orifice area, the best is to use the continuity equation, keeping in mind that mitral regurgitation or aortic regurgitation would influence that. In the guideline, these are the parameters that suggest significant stenosis, a very high peak velocity, high mean gradient, valve area less than 1, and a pressure half time that is rather large. There are limitations, obviously, for the pressure half time. We know that from even native mitral stenosis, but I think this is very important because this formula was not derived for function of a prosthetic valve. You can't use it when you have merging of ENA, delayed LV relaxation, decreased compliance. Obviously, these patients have had some issues with heart and ventricle coupling, significant aortic insufficiency. Therefore, always look at all these parameters together and even try to derive an effective orifice area using the continuity equation. That would help you. Well, almost through with more than half of the talk, and we haven't talked about transesophageal echocardiogram, because most of the time the evaluation of prosthetic valves are from the transthoracic approach. And the reason for it, it allows us different windows to be able to evaluate these velocities, and I think that's very important. What is the indication for TEE? Non-diagnostic or borderline cases, we really want to see what the actual structure of the valve in addition to function. Whenever there is concomitant regurgitation, particularly for identifying the site or the hiding in mitral regurgitation, or patients with known obstruction where you're wondering whether you want to use thrombolytic therapy in somebody who's high risk to undergo another surgery. One important point here regarding TEE and visualization is in the mitral position. It is beautiful, actually. You could see that. You could see the motion of the leaflets and everything about it, almost 100% visualization. In the aortic position, much more difficult because you're seeing on the side as opposed to en face, and this is among the more beautiful pictures. You won't see as well. So, I mean, a good evaluation is about 20% probably of the cases, true evaluation of motion of these leaflets and mechanical prosthesis. I know Dr. Sumin Chang will talk about it, but if you're wondering about whether in the aortic position, the leaflet motion is correct, is normal, you got to use some radiologic examination, either fluoroscopy, seeing it on the side, and there is a little skill, to try to get that, or by CT. And you could use CT with or without angiography, depending on the patient. If you use angiography, it will allow you to see the mechanism, just like you see a thrombus here, very nicely depicted on the right side of this mechanical valve. Now, for regurgitation, I think you need to know what normal is in regurgitation. In a bileaflet prosthesis, you may see like a triplet small jets as opposed to a monoleaflet where a central jet. And, Star Edwards valve, we don't see too much of them anymore. Importantly for us imagers in echocardiography is we have to be careful about shadowing and flow masking. In the aortic position, we don't have much of that because irrespective of the view, you're going to be able to see the depiction of the jet, and the shadowing is in the different direction. In the mitral position, it's a different ballgame. You will overshadow and mask, flow mask, not only visualization, but also flow when you use Doppler. And this is an example that I use, which is really very nice. You could see the reverberations from the prosthesis in the mitral position. You can take a look at color from the transthoracic window, and you really can't see much in there. You may see a little tiny jet, and that's all what you could see. However, if you go to transesophageal echocardiography in this same patient, you will see a different scenario. Even first, you'll see a large dehiscence of the prosthesis, a very large jet, very large vena contracta, really a severe mitral regurgitation in this. So as an imager echocardiographer, you have to keep your threshold high and taking a look at what are some of the clues that tell you that you may have regurgitation that you're masking. These are for mechanical prosthesis. Bioprosthesis are even a little higher. E-velocity greater than 1.9. A mean gradient not very impressive, just greater than 5. Elevated DVI, which is the reverse of the one for the aortic, greater than 2.2. Good LV function, but low systemic output, and pulmonary hypertension. Sensitive, but really not specific, because patients may have been left with pulmonary hypertension before. In the aortic position, much easier, because you don't have flow masking, and you use the same thing that you would use for native aortic regurgitation, with obviously be aware of eccentric jets because of depending what the mechanism of regurgitation is in prosthetic leaflets. Use pressure half-time, regurgitant volume. Also, importantly, diastolic retrograde flow in the aorta. I think that would be very helpful. So this is a TE to try to look at the mechanism of aortic regurgitation, and you could see it's an eccentric one, paravalvular, and also you'll see a mitral aortic intervalvular fibrosa. Not only a pseudoaneurysm, but also most likely an early abscess formation in this particular patient. So, and last is introducing that, in the past few years, obviously we're using TAVR to replace aortic valve. So it's a different disease in a way. You're using mitral clip for mitral regurgitation. Just few things to tell you. One, that there is a guideline within this past year, and that I would, if you're not familiar with it, I would urge you to take a look at that to help you in this evaluation. And TAVR aortic regurgitation is not an easy evaluation. At times you have punctate, small regurgitation, and not infrequently. These regurgitations are very eccentric, just like this amazingly eccentric one, and how you're going to be able to evaluate this. Now, if you're in the catheterization laboratory and the hybrid room trying to help the interventional cardiologist, echo will have limited views. Obviously, you do transthoracic and TEEs nowadays, less often than we used to do before, but you may have different sites. And the message here in the cath lab is, if you're in the extremes, it's easy. Mild or just severe, it's very easy. And the ones in between, we use more. We use, what the pressure waveforms are in the aorta, as well as in the ventricle. In addition, not infrequently, you may have to use, aortic root angiography to make sure that we don't have significant regurgitation because of limitations of the transthoracic or TE approach in the cath lab. Importantly here, because you have a lot of eccentricity of AR, you have to do a sweep from just above where the valve is all the way down to the ventricle, because otherwise, if you don't try to get the actual vena contracta, where the smaller area of the jet, you may overestimate the severity of regurgitation. You hear a lot about circumferential extent in vena contracta area. Extent is important, but it's not the whole scenario, because the extent may be small, okay, but the area of the vena contracta may be large. So you have to use both. The larger the extent, obviously, the more severe the regurgitation, greater than 30% or so. But at times you may have two areas of lesions that you have to summate and use vena contracta area. I just gave you the algorithm that we proposed. We're not going to go through it today, but to tell you that the things that will be specific for severe AR after TAVR procedure, a vena contracta that is large, as well as the area, circumferential extent that is greater than 30%, a pressure half-time that is short, not specific here though, and prominent holodiastolic reversal in the aorta. Mitral clip also can be challenging after a mitral clip, in the catheterization laboratory and afterwards. You may have different shapes and sizes and numbers of jets that you may be left with after one or more clips that you put in. You'd look in the catheterization laboratory not only at color as well as vena contracta. You could do that by 3D, but importantly as the pulmonary vein resurrection almost of the systolic wave, which has been shown as of late to be prognostically very important, right? And in the outpatient setting, if you have a tiny regurgitation, you know you're safe from that point of view. But if you have more than that, and with velocities in the mitral inflow that may be suggesting of more significant regurgitation, you have to do more. And not infrequently, a transesophageal echocardiogram, or refer it actually to our MRI colleagues to quantitate regurgitation. But if you're going to quantitate regurgitation from a ventricular output, total output, and LV outflow velocity, please use contrast to have more adequate ventricular size at end-diastole and in systole for you to be able to derive a total stroke volume in this situation. And this is the algorithm that was proposed for after repair of a mitral valve, the vena contracta area, a large flow convergence, a large jet, and pulmonary vein systolic flow reversal to denote significant residual regurgitation after an intervention. So in summary, from an echo Doppler point of view, one, what do we do? One is, yes, we need to have a clinical evaluation, know the valve type and size in these prosthetic valves, get a baseline echocardiogram and Doppler study after surgery, have a baseline transthoracic 2D Doppler for evaluation of structure and function, and it is indeed the first line diagnostic methodology. In cases where you have high velocity jet gradient and suspected stenosis of regurgitation, you have to do a few things. One, compare to a previous studies, and I think that's going to be very important. Nowadays, in the digital era, it is easier than what it used to be before. For aortic valve mechanical prosthesis, X-ray is really the first one to as opposed to a transesophageal echocardiogram. And the reason for it, you'll be able to see the motion as well as probably the mechanism of stenosis. TEE for the other cases, certainly for mitral, I think TEE is certainly very adequate and the preferred method. And CMR, and we'll talk about CMR also today with Dr. Shah about prosthetic valve, not only regurgitation, but I think this is where the limitation of echocardiography could be in quantitation of residual or new regurgitation in prosthetic valves. So I'm going to introduce Dr. Sumin Chang here, who will guide us through some of the evaluations of prosthetic valves using CT. Sumin?
Thank you, Dr. Zoghbi. Good afternoon. Okay, this is what we can see with CT, different type of valve.
Are you on? I don't see you there.
Get back. Great.
There we
So
go.
this is how different type of prosthetic valve look like in CT. On the left-hand side, you have biological valve, mechanical bileaflet, excuse me. Ball and cage. Again, this was a mistake. It's supposed to be a single disc Medtronic. You have a balloon expandable and a self-expandable TAVR, and then balloon expandable TAVR. Most important thing to remember is CT is not for routine evaluation. And you should consider using CT when valvular dysfunction or other complications are suspected. The reason we use CT because Dr. Zoghbi mentioned already there's some limitation with transthoracic and TEE, specifically related to acoustic shadowing and limited visualization of surrounding structure. So advantage of CT compared to TTE plus TEE are there's less artifact with CT, and isotropic spatial resolution is the best in all the non-invasive imaging. You have unlimited cross-sectional plane to reconstruct any structure you want. It provides better anatomical information with regard to perivalvular or annular structure. It will also allow us to reconstruct in three-dimensional fashion an anatomical relationship with other extracardiac structure, which is helpful for pre-surgical planning or guidance. And also very important is less discomfort for the patient. It's less invasive compared to TEE relatively. And also the study can be done with less than 1 minute. The disadvantage is it has a lower temporal resolution, and it has very limited to non-functional information since we cannot assess flow or hemodynamics. And obviously we need to use radiations and iodinated contrast. And for valvular assessment, we tend to use retrospective gating without dose modulation. So what are the roles of cardiac CT? I think there's two main components. One is for diagnosis, and the other one is for pre-procedural planning, which is another whole topic, so I'm not going to mention too much. Diagnosis of suspected prosthetic valve dysfunction, I think cardiac CT has an important role for specifically in suspected obstruction or stenosis. And we can confirm the obstruction usually after a transthoracic echo, and it helps to determine the etiology of the obstruction, which could change the management. Specifically for the aortic valve position, mechanical valve, we can assess the disc excursion, looking at closing and opening angle. For bioprosthetic valve, we can look at leaflet excursion, and we can look at anatomic orifice area. And again, we can distinguish pannus from thrombus, vegetation, and prosthetic valve patient mismatch. For regurgitation, is not as important cardiac CT for diagnosis because 3D TEE is exceptional. In some cases of prosthetic aortic valve regurgitation, CT could be useful in localizing the dehiscence and paravalvular leak, and obviously in cases of endocarditis or abscess, it can allow you to look at the extravalvular component. This is a kind of flow chart of what we think CT fit into the algorithm of evaluation of patient with prosthetic valve dysfunction. The most important thing I want to focus here is for prosthetic valve dysfunction, specifically obstruction in the aortic valve position. I think my detector CT should be sometime, I think, the first test of choice. And because of the current pandemic, if the TE is contraindicated or not desired in patient with suspected infection, multi-detector CT could be quite useful in supplanting TE. We're going to show you some quick example. I'm going to run through some quick cases. 2 cases of patient both with prosthetic mechanical bileaflet aortic valve, both presented with heart failure. Both had high gradient. As you can see, this is the first patient. This is a transthoracic. The Doppler is quite useful. It's very high gradient with a mean gradient about 35 and peak gradient 54 with a very small valve area. And TE, not sure why it's not playing. There we go. TE show this flow acceleration, confirming there's obstruction. There's not much. There's a little bit of regurgitation, probably moderate regurgitation. However, the etiology of the obstruction become apparent with the cardiac CT. As you can see here, there's subvalvular hypoattenuation. This is consistent with pannus formation. It was confirmed by after surgery. A patient had a redo mechanical AVR with good prognosis, with good follow-up. This is another patient who has also elevated gradient of up to almost 5.5 meters, and also quite significant regurgitation. As you can see, TE was not able to provide the etiology of the stenosis, And with the performance of cardiac CTA, you can see there's two images with low attenuation actually localized in different part of the prosthesis. As you can see, one was supravalvular and one was subvalvular with slightly different attenuation. One is the supravalvular one, the attenuation was around 70, and the subvalvular one is around 240. This is one of the 3D rendering of the mass. Patient was suspected to have prosthetic valve thrombosis, and heparin was started with improvement of the gradient. However, the follow-up echo showed still have some elevated gradient. The patient was doing much better. As you can see in the follow-up CTA, the supravalvular area has completely resolved, consistent with thrombus, and the subvalvular right here, hypotension persists and with impediment of the excursion of the leaflet. So this is a very interesting case of patient with both mixed thrombus and pannus. This is kind of a quick summary of difference between pannus and thrombus. Again, want to emphasize thrombus is mostly supravalvular with low attenuation. Pannus is usually subvalvular and with higher attenuation similar to soft tissue. Just quick, some example of obstruction. This is pannus in a bioprosthetic valve. This is a degeneration changes a patient in dialysis after a balloon expanded TAVR. This is a degeneration of biological prosthetic tricuspid valve. And this is a case of clot in a control expansion TAVR with 4D dynamic CT showing the two area of thrombosis in the aortic cusp. This is a cases of TMVR thrombosis. And this is a cases of defective prosthetic valve. For quick review of regurgitation lesion, I think, as I mentioned, 3D TEE for mitral position is unparalleled, and CT could help sometimes for localizing and sizing the leak. And in case of, again, redo procedure or paravalvular leak occlusion, CT could be helpful, especially in the cath lab for fusion guidance. This is just some example of paravalvular leak, aortic valve, prosthetic valve, and a mitral valve. This is a case of what I call pseudo paravalvular leak because it truly is an annular ring dehiscence, and so the regurgitation is really not paravalvular, but rather valvular through the dehiscence. For endocarditis, I think it's very important to get us to obtain a CT because to evaluate the extension of the abscess. All right.
You okay?
PowerPoint just stopped working. All right. That's unfortunate.
Little technical issue here.
Yeah. It's stop working in the middle. All right. Yeah.
Where?
Okay.
Okay, so while you're wrapping up, let me go ahead and start with CMR, and then we'll wrap up with CT at the very end here. So a few things, obviously, I can't tell you how often I get asked a question, can we scan a patient with a prosthetic valve? And so obviously the reason that we're concerned is because you don't want to have a catastrophe occur. You don't want the valve to be migrating. So, but the reality is that most of the prosthetic valves, even the mechanical valves that we utilize today, have been tested and are not really of a concern for migration up to 4.7 Tesla. So the reality is for most clinical scanners that we use today, the 1.5 and the 3 Tesla scanners, most, if not all, of the mechanical or bioprosthetic valves will be safe to image in an MRI scanner. The obvious exception to that is now that we have 7 Tesla MRI scanners, we need to go back to the drawing board and figure out the safety of those. The other question, though, I think the bigger concern is what's the amount of artifact that you're going to get from the prosthetic valve. And so I think that really is going to depend from valve to valve, but I think a big distinction is going to be whether it's a mechanical prosthesis or it's a bioprosthetic prosthesis. And so here's an example of a patient with a mechanical aortic prosthesis, and you can see that the amount of the artifact that you get here is actually quite substantial. And so if we're trying to measure velocities at the level of the valve itself, that could be somewhat problematic. On the flip side, with most bioprosthetic valves, although there's some localized artifact at the struts, the majority of the valve doesn't cause that much of an artifact that you can generally assess for stenosis within these valves. And so I'm going to kind of walk you through how we approach both stenosis assessment as well as how we're going to try to do regurgitant assessment as well. So first thing is for stenotic assessment, if we have a bioprosthetic valve, there's 2 key pieces of information that I think we're going to try to assess. One is, what is the anatomic orifice area? And so again, that's going to be similar to what we would do for a native valve, as we talked about, I think, in a lecture a few months ago, where we're going to do a series of the SSFP cine images at the leaflet tips to then try to be able to planimeter the size of the orifice in peak systole. The key here obviously is that you want to make sure that you have a good enough view that you can see the valve leaflet tips themselves, and then you want to make sure that you're at the very tips of the leaflets, because obviously if you're too low, you may get an underestimation of the severity of the stenosis. So again, this gives you anatomic orifice area. The other thing that we'll typically do, just like we do for native valves, is try to determine what is the peak transvalvular velocity or gradient. And that's going to be done utilizing our phase contrast CMR technique. And I've shown you here an example of a phase contrast CMR that's done in an aortic bioprosthesis at the tips of the leaflets. And then from this, we can actually measure what is the peak pixel with the highest velocity during systole, and from that determine what is the peak velocity or the peak gradient at this prosthetic valve. And in addition to that, what can also be done is what was done very nicely in this study from a few years ago from one of our former fellows, where they actually took the velocity profile data at the level of the valve and then compared that to a normal reference point, either subvalvular in the LV outflow tract, or you could actually do it in the ascending aorta as well. The idea being is that we could apply the same principle that's used for echo to determine a EOA or effective orifice area, which is more of a physiologic measure, and then using that continuity equation by having the area and the velocity profile at a normal reference area, whether it's the LVOT or the ascending aorta, and then also having it at the level of the prosthesis itself, we could then calculate the EOA. And this very nicely shows the relationship in this series of close to 100 patients between the EOA that was derived by phase contrast CMR and the EOA that was derived by echo Doppler, showing in fact a fairly nice relationship and a bland Altman that showed limits of agreement of really within 0.2 to 0.3 centimeters square. Now, let's turn to regurgitant lesions, and I think this is the area where CMR is going to have the greater strength. And so how do we do regurgitation assessment by CMR? So if we're talking about for the aortic valve, kind of the preferred method that we're going to utilize is a technique where we use our phase contrast CMR and we place a imaging volume above the aortic valve, so within the aortic root. And then from this, we're able to derive the direct retrograde or reverse flow that's happening during diastole. And in this normal case, there was about 80 cc's of reverse flow in a native valve, I should say. Now, in a prosthetic valve, or let's look at even these percutaneous prostheses like a TAVR valve, here's an example of somebody who has paravalvular aortic regurgitation. And you can see actually very nicely if we look at this view right here, which is at the left ventricular outflow tract area. And again, this is a through plane or a cross-sectional view. We can see the systolic forward flow, which you'll see in black, and then you see the diastolic retrograde aortic regurgitation flow, which is in white. And we can actually quantify this by two methodologies. One would be by, again, placing a phase contrast in the ascending aorta distal to the prosthesis. And from that, we're able to determine that there's actually, during diastole, about 45 cc's of retrograde flow that occurs during diastole. A secondary method that you can do is actually to place that phase contrast CMR imaging plane a little bit lower and place it in the left ventricular outflow tract proximal to the prosthesis. And from this, then, we're able to derive what is the forward flow in the left ventricular outflow tract and compare that to the net pulmonary artery or the systemic flow and use that to determine what is the regurgitation. In this case, the LVOT forward flow was 100 cc's. The net PA flow was 50 cc's, telling us that there's about 50 cc's of aortic regurgitation here. And then a regurgent fraction is simply dividing that by the LVOT forward flow to, in this case, derive a regurgent fraction of also 50%. A confirmatory check that can be applied just as we do in native valves, you can also do this in prosthetic valves, is to look at the descending aorta and look for holodiastolic flow reversal in the descending aorta, just like you do with echocardiography. And again, that's a very specific marker, but not as sensitive for identification of severe aortic regurgitation. So this example patient that I showed you here actually did go on then to go for a redo procedure where the severity of the AI was confirmed by aortography, and he went on to have the TAVR valve redeployed. And then was doing clinically much better on follow-up afterward. So there's actually a very nice study from a Canadian group which looked at a series of about 150 patients post-TAVR to identify paravalvular regurgitation by CMR and to correlate that with outcomes. And what they found was that for those patients who had, by CMR, a regurgent fraction of more than 30%, the prognosis was worse, whether we look at all-cause mortality or at all-cause mortality as well as rehospitalization for heart failure, compared to those patients with paravalvular AI of less than 30%. And again, a couple of other interesting findings in these post-TAVR patients, because again, this is now a common scenario as many of the aortic stenosis treatments have moved away from surgical to percutaneous treatment. We come across these patients not infrequently. What they found was that in these post-TAVR patients, one is there's a worsening outcome with increasing severity of regurgitation, that the outcome threshold was really a regurgent fraction of more than 30%, that regurgent volume itself was not very predictive of clinical outcome in paravalvular AI post-TAVR. And again, there may be several reasons for this. One is that this is a ventricle that was really an AS ventricle that all of a sudden now is seeing aortic regurgitation. So this may be a little bit more analogous to acute AR, and it may not be tolerated nearly as well. The fact that these ventricles tend to be very small cavity sizes to begin with, and that there's significant underlying concentric hypertrophy in these patients. And then also I think the fact that because many of these patients will have a low flow state, a small regurgitant volume may represent a large regurgitant fraction. And as a result, again, regurgitant fraction was a better predictor than regurgitant volume was for outcomes in post-TAVR paravalvular AI. Now, let's move to the mitral valve. And again, a common scenario we'll have is a patient who's had a mitral repair or a patient who's had a mitral prosthesis, whether it be mechanical or bioprosthetic, and there's a question of regurgitation. So how would we do assessment of regurgitation in a mechanical prosthesis? Well, in fact, the methodology that we utilize is the same that we would utilize for a native valve. And again, as you recall, the way that we do native valve assessment is actually by what's called an indirect method, where we compare the stroke volume of the left ventricle by planimetry of the cine images to the flow going out of the aorta by phase contrast. And so again, notice none of this involves direct imaging at the mitral valve level itself. And as a result, even if there's artifact at the mitral valve, it's really not going to impair your ability to do a mitral regurg quantification. And so here's an example in a patient who had a LV stroke volume that's 157 cc's by planimetry of the cine images, but aortic outflow is 82 cc's. That means that the rest of that flow, the difference between these two, has got to be going retrograde back into the atrium and therefore represents a prosthetic mitral regurgitation. Now obviously this applies as long as there's not a VSD or some other source of unloading of the left ventricle. But again, so for the vast majority of the cases, this formula in and of itself would apply very nicely. And so in this example patient that I showed you with the mechanical prosthesis with paravalvular regurgitation, this person has now 75 cc's of mitral regurgitation, which really corresponds to severe mitral regurgitation. Now, I talked to you about some of the strengths of CMR. I also want to highlight some of the limitations. Now, since CMR is typically acquired in what we call a segmented fashion, where one image is acquired over several different heartbeats, something like endocarditis can be challenging to identify. In this example case, we can actually see a nice vegetation, but there are many cases where you could see a vegetation by echo that's very small, that's very highly mobile, that you would not be able to pick up on a segmented acquisition by CMR. And so as a result, I think it's important to recognize the strengths as well as the limitations of each of our modalities. So to wrap up, what can CMR do? So I think one is it's not ideal for assessment of vegetations, and it's also not ideal for assessment of mechanical prosthesis where you're trying to determine what the gradients are. So mechanical stenosis is not a good application for CMR. Bioprosthetic stenosis, I think, is. And then I think certainly any valvular regurgitation, whether it's a mechanical valve, a bioprosthetic valve, or a transcatheter valve, CMR could be useful in that setting. So I'm going to turn it back over to Dr. Chang, and then you've also got kind of an algorithm that we have. So let me go ahead and turn the floor back over to Dr. Chang, and then we'll wrap up with this algorithm right here, which Dr. Chang will come back to.
Yes, thank you.
So can you guys switch over to?
I just have a couple more slides. We just show this.
Okay, sure. And while we're waiting for Dr. Chang to get started, please text in any questions that you have. We're going to put that number up there and just text in DeBakey, or go to Poll EV, Poll Everywhere, and text in your questions as well. And then we'll have some time at the very end for some questions.
Do we need to?
And while we're wrapping up, let me just go ahead and let me just keep this. Let me just go ahead and go through the algorithm. Why don't we just go ahead and wrap up, and let's just go through the algorithm that Dr. Chang and I have proposed. For when you use advanced imaging, so obviously you start off with echocardiography, and so the transthoracic echo is going to be your first line modality. But then in cases where you're concerned about obstruction, that's an area where either 3D TE could be useful, or CT could be useful, especially if you're wanting to assess for obstruction of the aortic valve. And I think the strength of CT there is that it may also be able to help you to identify or to discriminate between thrombus versus pannus. CMR could be helpful for stenotic lesions, again, if we're dealing with bioprosthetic valves, but not for mechanical valves. And then for regurgitant lesions, I think that's a case where CMR could be helpful for severity TE or CT could be helpful for mechanism. And then obviously transesophageal echo also has a significant role as well. And so,
why don't we wrap it?
yeah, why don't we go ahead and wrap up and let's take time for questions. Yep.
So the question to you, why don't we have a discussion here and answer the questions that are sent. Question to you, Dipan and Sumin. One, do we agree that any evaluation of prosthetic valves has to start with a Doppler echocardiogram?
Yeah.
Truly. And I think
Yeah.
then it's very important for us to know the limitations of each one of the techniques and where does it fit. I can tell you from even doing a lot of TEs and stuff, if the concern is on a mechanical prosthesis, is there dysfunction in the aortic position? To me, TE is not your first choice. Unless you're looking at regurgitation is different, but function, you have a high gradient, right? You have a high gradient, and the question is this an obstructive valve? Is this prosthesis mismatch? Is there a pannus? Is there a thrombus? I think CT would be king in this situation.
Absolutely agree. And we have published a study showing that for prosthetic aortic valve obstruction, CT offers a slight advantage over TE in determining the etiology.
And also, this is not where CMR is. I mean, CMR, yes, if you're doing the study, you can get the gradient, but you're not going to look at the mechanisms of the valve itself. Is it opening well? Is there a thrombus? Is there, right? Regurgitation, I think probably CT would not be the first for regurgitation. Echo Doppler, transthoracic, some TE to evaluate the mechanism of regurgitation can help you. But if you're really concerned about quantitation, right? And you need that quantitative parameter to try to understand it in those situations, CMR is probably the way to go.
Yeah, I agree with that. I think that the nice thing about regurgitation is that for most of the methods that we utilize, we don't need to image directly at the valve itself. We're actually imaging at a location different to that to determine what is the regurgent volume. And then in addition to that, you obviously get the information about remodeling of the ventricle, which again is going to be very important from a timing standpoint of when you're going to think about doing something for these patients.
And for mitral, as I mentioned, for mitral, looking at mechanism or stenosis, TE does very good with Doppler and transthoracic because you are down the barrel of the valve, so you can see the whole, whether it's paravalvular or intravalvular, whether the mechanism of opening and closing of the mechanical prosthesis, I think is very good. The question is, in regurgitation, estimating if you need the quantitation, I think CMR is probably the way to go.
Yeah, one of the potential role of CT is in those patients, most of them we think they have severe regurgitation or obstruction, that clinically we know they need something to be done. For instance, percutaneous procedure or redo valve surgery. And oftentimes, for surgical planning purposes, a CT is older. So sometimes my suggestion is always, if you could go back and review specifically for those regurgitating lesions, before you do the TE or review the CT, I think for our fellows who does multi-modality imaging, I would strongly recommend that before you review your CT or perform your TE, review all the study together before you do the procedure. We have encountered some cases that CT was done and we suspect 3 paravalvular leak, and TE, unfortunately, we will only be able to see 2 and cannot exclude the 3rd one, for instance. So that would be, I think, very important to fellows or whoever performs the procedure to review any available study before we do the procedure.
Very important.
Yeah, I think I agree with that 100%.
We don't want to layer one study after another after another. A question to you, Dr. Shah. Do you wait 6 weeks after valve placement before performing a CMR like MRI, condition devices, etc.?
Yes, so that's a very good question. So, and the reality is that the reason that we recommend waiting 6 weeks for a pacemaker or defibrillator for a device is actually not so much because you're concerned about migration or lead dislodgement in the first few weeks. That's a very small risk. The reality we wait is because we want to make sure that the pacing and defibrillation thresholds are stable. so that when we were initially doing the studies for pacemaker and device safety, we didn't want to see a change in thresholds that was actually just due to the natural change. So that 6-week recommendation has actually been softened now in clinical practice. And so for valves, you don't need to wait 6 weeks either. Yep. So
Wonderful.
I think you can do it, a few days after. Yep.
Wonderful. Well,
All right.
has been a great discussion, and thank you very much, and thank you for our viewers to follow us on YouTube and our multimodality imaging lectures. We'll see you next week.
Great.